Hmm. Okay, good morning. Today's IC session is a video assisted skill transfer course on lasers in glaucoma. Laser has revolutionized glaucoma care, and it is effective, minimally invasive approach to lower the intraocular pressure. And through this video assisted course, we will be exploring different types of lasers used both in open angle and angle closure glaucoma as well as in refractory glaucoma. And also we'll be exploring the emerging laser technologies. So first I would like to introduce Dr. Roshna, who will be talking on laser procedures, introduction and consent. Dr. Roshna is a glaucoma consultant at We Trust Eye Hospital, Calicut.
Thank you for the introduction. Thank you for this opportunity, Dr. Nimita. My topic is introduction and consent to laser procedures in glaucoma. So, what is the importance of laser light? Laser light, when compared to incandescent light, it is monochromatic, it is directional and coherent. The laser journey started from the 1961 by Campbell and Riddler. They used for retinal photocoagulation, and in 1962, laser used by Worth and Wickham for the anti-tubercular meshwork. And 1962, the Krasnov introduced the laser iodotomy. 1972, Becker and colleague introduced the ALT, argon laser trabeculoplasty. In 1990s, diode was introduced for refractory glaucoma. In 2000, Latner Park introduced the SLT, and in 2010, micropulse diode laser was introduced. Lasers used in glaucoma is argon blue green and green laser, and diode laser, Nd:YAG laser, and carbon dioxide lasers. What are the type of lasers? We have gas lasers, chemical lasers, solid state lasers, metal vapor lasers, and semiconductor lasers. What are the mechanism of lasers in human tissue? First important mechanism is the photodisruption that is used in the Nd:YAG laser. This high energy light is deposited over a short interval to a target tissue, and there will be a striping of electrons, and these electrons will form a cloud, and ionized molecule constitutes a plasma, which then rapidly expands and causes a acoustic shock wave that disrupts the tissues. That is used in the Nd:YAG laser, YAG laser, peripheral iodotomy. The next important mechanism is the photocoagulation. Absorption of light by target tissue results in temperature rise, which causes denaturation of proteins that is used in the argon laser and tryptophan lasers. And next important mechanism is the photoablation. When high energy laser wavelength in far ultraviolet region of spectrum is used to break the long chain tissue polymers into smaller volatile fragments that is used in XMR lasers. Another important mechanism is the photochemical or biostimulatory effects that is used in a micropulse mode or lower level laser therapy to modulate the inflammation or metabolism, and they will induce the biochemical changes in cell through cytochrome oxidase activation and reactive oxygen species that is used in the micropulse diode laser. What are laser procedures in glaucoma? First important thing is the laser peripheral iodotomy, that is producing a hole in the peripheral iris and fluid is maintained between the anterior and posterior chamber that is used in the angle closure glaucomas. Next one is the laser adoplasty, that is circumferential 360-degree laser is applied to peripheral iris and the peripheral iris is pulled away from trabecular meshwork, that is in the posterior angle closure and plateau iris and ophthalmos. Next one is the laser trabeculoplasty that targets the trabecular meshwork in the anterior chamber to improve the aqueous outflow. And laser suture lysis, the suture is lysed with the laser after in postoperative mechanism, postoperative setups. And in laser blood remodeling, it can be performed to treat the problems like filtration and leaking or large encapsulated symptomatic blood by using a laser to shrink or modify the blood structure. We are using a Nd:YAG or argon laser for this. And laser synecholysis is to prevent the adhesion between the iris and lens capsule. Laser is used. Then next is the laser cyclophotocoagulation, the destructive laser procedure done to the ciliary pigment epithelium to reduce the aqueous humor production in refractory or end-stage glaucoma. There are different types of cyclophotocoagulation: transclear, endoscopic, and micropulse. We are coming in detail to each and every session in next sessions. Okay. Next important thing in the every laser procedure is the consent. So the consent form should start with the patient identification. The name, age, and hospital or clinic number should be written in the consent form, and the eyes to be treated should be mentioned. And next, we have to describe the procedure. We have to clearly describe the procedure in lay terms. For example, laser treatment to the drainage area of the eye to lower the eye pressure. And the laser peripheral iridotomy, we have to mention it as creating a hole in the iris to create the increase the fluid flow. And laser trabeculoplasty, that is treating the drainage meshwork to improve the outflow. And laser cyclophotocoagulation, that is reducing the aqueous production by treating the ciliary body. And in lay terms, we have to mention like this. And the next important thing is the purpose and indication. Explain why the procedure is being recommended to lower the IOP, to prevent the slow progression of optic nerve damage, and to avoid or delay the need of surgery. Then we can also explain the expected benefits, that is reduction of IOP, possible stabilization of glaucoma progression, and short recovery time as compared to the surgery. And we have to mention about the details of the procedure. That is usually it is a OP or OT procedure done under topical or local anesthesia, and duration of the treatment, pupil dilatation or constriction needed, and possible temporary discomfort or blurring of vision or light sensitivity we have to mention. And the risk and possible complication we have to mention. It will be specific to laser type, but generally it include eye irritation, pain and headache, transient blurring of vision, inflammation requiring the additional drops, and temporary or permanent rise of falling IOP we have to mention, and need of repeat treatment or further surgery also we have to mention. Specific to each laser, in laser peripheral iridotomy, we have to mention about the glare, halos, and double vision, and bleeding at the iris and closure of iridotomy chance we have to mention. And SLT and ALT, IOP spike, failure to reduce the pressure, rare but permanent damage to trabecular meshwork also should be mentioned in the consent form. And in the cyclophotocoagulation, we have to mention about the inflammation, hypotony, vision loss, shrinkage of the eye, phthisis also we have to mention. And in the case of diode cyclophotocoagulation, surgeons should warn the patients about the postoperative pain and some reduction of vision, and more than one CPC session we needed to achieve the desired control of IOP we have to mention. And we have to mention about the postoperative care and use of anti-inflammatory and pressure lowering drops, and possible need of follow-up IOP checkups we have to mention, and avoid rubbing of the eye, and if report if there is severe pain or blurring of vision. And the prognosis and limitation we have to mention in the consent form. Laser may not eliminate the need of AGM, anti-glaucoma medications, and effect may bear off over time, especially in the case of SLT. And repeat treatment we have to mention. And the consent of acknowledgement, patient should sign to confirm, and patient and bystander signature should be there like this, and the doctor declaration should be there, and the physician name and signature should be there, and the witness's name and signature should be there in the consent form. And we have to take consent for the optional clause for any permission of the photographs or data use, and consent for emergency management of complications. And there should be a closing statement. It should be like this: I understand that the laser treatment for glaucoma is intended to lower my eye pressure and help prevent further vision loss, but it may not improve my current vision or eliminate the need of medication or surgery. Thank you.
So next, I invite Dr. Veena Vishwan. She will be talking on selective laser trabeculoplasty. Dr. Veena is a glaucoma consultant working at Amardeep Eye Care.
Good morning, everyone. First of all, I thank Nimita for giving me this opportunity to present here. So I'll be talking about selective laser trabeculoplasty. I know that many of you are not aware of this procedure. This is a recent procedure. It started in the early 2000s, and still many of the hospitals are have just started using it. And so I would like to give you an idea about what I am doing. We have been doing it since the past 2 years, and our experience and basics about how the procedure should be done, what all you should be doing, is what my intention is to speak here. So, as the name indicates, it is a selective laser procedure. It improves trabecular meshwork damage because the laser acts on the melanocytes of the trabecular meshwork. When the laser falls, the melanocytes absorbs the energy, and only the melanocytes are affected during the procedure. So, to see the trabecular meshwork, the angle should be open, right? So, a good open angle is the need for a case whom we select for trabecular selective laser trabeculoplasty. So, this procedure can be done in POAG patients, pseudo exfoliation patients. In our experience, have good results. Pigmentary glaucoma, because of increased number of melanocytes, maybe they also respond very well. Then in normal tension glaucoma and ocular hypertension also, nowadays selective laser trabeculoplasty is being used. So as I mentioned, a good gonioscopy is mandatory, and we have to see all the angle structures. The angle should be wide open. Otherwise, whatever photo disruption may cause a peripheral anterior synechia formation later. Okay. So coming to the procedure, we have to do a gonioscopy. So topical anesthesia, in my routine procedures, I put topical anesthetic before 2 minutes because I want my patient to be still during my procedure. So I would advise you to do the same, and always mark the eye. Mark the eye. This is a small procedure. You may feel that the patient is not having any problem, no pain or bleeding or anything, but still understand the importance of marking the eye and taking the consent. My previous speaker, she has beautifully given you an idea of what consent should be taken. So even the Malayalam print which she showed is very good. I would like to get it from her, because we usually give an English consent and it was beautifully written. So thank you for that. Now coming to the procedure, the frequency is 532 nanometers. The same Nd:YAG laser is frequency doubled and used in this procedure. The spot size is larger. You know that in argon laser, the spot size is very small. We have to focus. But in this is a comparatively less skill only is required. This is not a procedure which requires lot of skill. So the spot size is large. On the trabecular meshwork, you can focus. Okay, it is a continuous sort of, we give the spots in a continuous sort of way. The pulse duration is 3 nanoseconds. So the thermal relaxation time of the tissue is more than this. So there won't be any burns happening at the area. Then the energy is 4.4 to 1.2 millijoules. In my experience, within 1.4 to 0.6 itself, this champagne bubbles, we won't see any change there. Like in iridotomy, we see what is happening. But here, there won't be any visible change. The only visible change we see are bubbles coming. So that is called champagne bubble appearance. So I'll show a video. See, this is how we do. We focus, we try to make the spot clear on the trabecular meshwork, and continuously, without overlapping, continuous shots are given. Can you see the small bubbles coming? Those are called the champagne bubbles. Okay. This is taken as the endpoint. And when the champagne bubbles come, we reduce the energy a little bit and then give. So champagne bubble is taken as the endpoint. Usually I select the inferior angles first because it is the wider angle. It is the widest angle in any eye. So for easy doing, I select the inferior angles first. So you have to focus on the superior mirror and do continuously. 25 shots each quadrant. So 180 degrees, you give 50 shots. When you come to the edges of the mirror, it is difficult because focusing is difficult. You have to get a skill to tilt the mirror and look at the side and give the shots. Then these are the small practical difficulties. Some studies say that champagne bubble formation is a false endpoint because there is not much histopathological changes happening there. Then this is a word about the machine I already mentioned. It is a Q-switch frequency double laser. The mechanism is not photocoagulation, it is photo disruption of the melanocytes. Now always record what you are doing because in an iridotomy you can see what you have done. After 1 week when you call the patient, you won't remember which angle you have given. So always draw a picture, draw a line and mark the quadrants and draw what you have done. Then consent, I already mentioned, small, there won't be much bleeding, there won't be much inflammation, but mention all that in your consent form. Mention that there won't be much reduction of IOP. Mention that there may be hike in IOP. Okay. So why are you doing the procedure? Talk to the patient that what to expect. There won't be any dramatic change. Repeat the procedure if it is needed. So, and you may need medication later. That also you should tell the patient. A practical way of dealing with it is tell the patient that you may be able to stop one medicine. Then the patient will be expecting that only. You may be able to stop one medicine after this procedure. Then post-treatment, how do you know small variations in IOP? You have to be very clear how much IOP has come down. So applanation tonometer is my way to go. And I use the same tonometer. We have so many applanation tonometers, but I take it in one tonometer before and after the procedure. You can mark the tonometer as a tonometer 1, 2 or something. If you are taking RT, mention that. If you are taking NCT before and after, mention that and record everything. Then I do it after 30 minutes, then after 1 week, 1 month, 3 months and 6 months. We have 2 years data and many a times there will be variations which should be recorded properly. Then there may be examiner bias also. Always the same examiner better to record because for some people wider Myers and will be their endpoints. For some people the thin Myers will be their way of taking the IOP. So if the Myers are wider, you know that the IOP will be falsely high. And if the Myers are thinner, you know that the IOP will be falsely low. For different examiners, it's not good to take for the same patient for follow-up for this procedure. So post-operatively also, I don't give steroids because steroids may slowly increase the IOP. So I give nepopenic eye drops. There will be only minimal inflammation. And I think that is enough. For all my patients, I have never had an issue with this. Then best results are in treatment-naive patients. Delayed response is very common in SLT. So many patients who had a hike in IOP, after 6 months or so, when we check it again, the IOP has drastically come down. So be patient, it will come down. In my experience, SLT is very, very useful in your treatment of primary open angle glaucoma. Don't use it in narrow angles like NVG, angle recession also, don't use it. And the most important advantage is that it is repeatable. You can do it again and again and it's less costly and patient compliance is better. Disadvantages, sometimes you have to be patient. Sometimes it won't work when you want it to. Then so many studies have also, that light study, NICE guidelines, all advocates the use of this laser. So in my experience, SLT is a very good weapon in your armamentarium for treating glaucoma. You can start using it. Okay, thank you.
Thank you, Dr. Veena. Thank you, Roshna. I forgot to mention. So next, Next talk will be by Dr. Satyan sir. He is not, unfortunately he couldn't come today, so he's given a voiceover. He'll be talking on laser for angle closure glaucoma, laser iridotomy and iridoplasty. Sir is the, wait a minute, wait a minute, wait a minute. Sir is the president of GSI and director of Satyan Eye Care Hospital, Coimbatore. So he'll be talking on peripheral iridotomy and iridoplasty.
To reduce the risk of chronic eye closure. There are a few safety precautions one has to look into, like a bleeding disorders, or the patient is on any anticoagulants. You have to take caution. Once you do the ablation iridotomy, you may come across having the high fever. It could be sometimes vision threatening. So you have to be cautious. The consent form has to be given to the patient. Any procedure where you take the consent, similar to that, you take the consent form from the patient before you do the procedure. There are several risk factors, very minimal, but IOP spikes can be seen in few cases. The visual dysphotopsia and the corneal damage also in the across in few patients. The pre-procedure preparation is extremely important. By constricting the pupil by using pilocarpine 2%. Apply the medication and wait for at least half an hour to 1 hour. Like once the pupil stretches out, then it is easy for you to do the guideline. Once the pupil is constricted well, then there is a time where you can really identify the fits and you can perform the guideline quite comfortably. Sometimes the pilocarpine can give some headache, but you can talk to the patient. When the complaint to much of a headache, then probably you may give the paracetamol tablet. There's an alternative way if you don't want to use the pilocarpine. You shine the torch in the other eye, and the eye which you want to do the laser, you shine the bright light from the slit. Because of the tensions will reflex, you can see the pupil is getting constricted. So this is a very sustained reflex once you put the light in the eye. And this is very useful in cases where you don't want to use the pilocarpine. Once you can see the clips by showing the light in the laser eye and other eye you show the light torchlight, then it is an easy procedure to perform. It's not very difficult procedure. So the next thing is preparing your machine. One may have different, you can have different machines. So I'm not going to discuss about the machines in detail, but there are Indian machines and also the imported machines. Imported machines mostly uses the Gaussian mode where you may have to use the power settings around 4 to 6 millijoules. In Indian machines where it uses the super Gaussian mode, you may use about 2 millijoules as the power. So I use this machine, so I have my settings at 2 millijoules. And using the lens becomes mandatory in most of the cases. But if you have a clips very well seen and a thin iris, you may avoid sometimes using the lenses. So lens will give a good control over the eye. The laser beam is focused sharply and which really helps you to minimize the laser loss. And also it can really help you whenever you see a minimal bleed or microbleed or microhypema. Lens is pretty useful when you're doing the laser. So this is how you have to do the abundance. Ask the patient to relax and break the lens points. Always use the focusing light of the slit so that the other eye patient can look at the fixation light. So then it becomes easier for you to do the others. So the first step is once you put the slit on and you can see the fixed well, that is where you have to really do the laser, then in the thinnest areas. Then you can see the positioning of the PI. It is between the colorate and the peripheral iris. Don't go too much into the periphery also. Same way, don't come too close to the colorate. Somewhere in between you can come the PI, something like this. You can see the very clearly. This is the positioning of the PI, and you can do any of the locations. I preferably avoid the superior because patients may have the visual dysphotopsia more than they are doing the superior. There are several publications to show that the superior location has more potential for a visual dysphotopsia. These are the size of the PI. Don't have to do too large a PI. If you do a larger PI like this, one may encounter having the central lens because of zonular ruptures in the property. So try to avoid doing any large PIs. So looking at the end point, the moment you do the laser, you look at whether there is a gush of aqueous coming in. You can just magnify if you feel that it is too small, the magnification, so you can really appreciate the gush of aqueous coming with the pigments coming into the anterior chamber. And also sometimes you may appreciate the deepening of the anterior chamber as well. So that is the end point. Post laser medications, you can use the steroids 4 times in the tapering dose over a period of 7 days to 10 days. And you may give timolol if the patients are not comfortable taking the acetazolamide tablet, because not everybody is very comfortable taking acetazolamide for a couple of days. Or if you are giving timolol, if you feel that IOP needs to be controlled, you can give it timolol daily doses. So post laser, you see the IOP, and also you have to do the gonioscopy and follow-up visits to see that probably the angle opening has happened. It will really help us understand that. So these are the several complications, but the commonest ones may be the microangiomas. Rarely you see pupil distortions and also blurred vision. Inflammation sometimes my patient appreciates by telling that when they feel the glare of the stoppage of the steroids. So you can increase it for a few more days, number of days, so that it becomes reduced. The patient becomes more comfortable. Increased IOP is another one. Then visual dysphotopsias. But whenever you are taking up these patients for a cataract surgery post laser PA, as I mentioned earlier, you look at the zonal ruptures. About the laser hydroplasty, it is not a very commonly done procedure. From this slide, you can see that there are a lot of laser marks in the peripheral laser, but we usually use argon laser so that it constricts. So you have to use a photocoagulator and then you are doing the hydroplasty. The peripheral iris is getting contracted, so the angle opens up nicely. To a reasonable extent, if there is no synovial closure. If there is a synovial closure, you may not really appreciate. You can see the other eye. Once the IOP comes down to a reasonable extent, you may do the laser, like SLT, or if you want to go for, in spite of all this IOP is high, you can go for an hemophilectomy. So in short, we have discussed about the CAD laser peripheral hydrotomy as well as on the hydroplasty. Thank you so much.
Thank you, Dr. Satyen. Our next topic is diode laser cyclophotocoagulation by Dr. Nimita. Dr. Nimita is a consultant glaucoma specialist at Complex Eye Hospital, Calicut.
So, good morning. Thank you, KSOS, for this opportunity. So, I'll be talking on diode laser cyclophotocoagulation. So, cyclodestruction mainly aims to reduce the aqueous humor production through coagulation or destruction of the ciliary body. So, there are various ways, that is the cyclodiathermy, cyclocryotherapy, cyclectomy. All these causes prolonged uveitis, damage to the corneal nerves, eye pain, and phthisis. whereas laser cyclophotocoagulation mainly has a targeted approach to the ciliary body. So, laser cyclophotocoagulation, first it was done with ruby laser, followed by ND-YAG, and then later diode. In the ND-YAG laser, the wavelength used was 1064, and there are two types. There's the non-contact ND-YAG and contact ND-YAG. In the non-contact slit, it was done using slit lamp with or without a contact lens, and the laser is aimed at 1 to 1.5 millimeter posterior to the surgical limbus, whereas in the contact ND-YAG, it is using a sapphire probe, and the laser was aimed about 0.5 to 1 millimeter posterior to the surgical limbus. In both the superior and the inferior 270 to 360 degree quadrant was treated, avoiding 3 o'clock or 9 o'clock position. So here in ND-YAG, it penetrates the sclera, but the melanin absorption was less in ND-YAG. So as a result, it caused lot of collateral damage. So then came the diode laser cyclophotocoagulation, where there is where it uses lesser energy, better absorption by the UVA melanin. There is quicker and greater durability, and it is portable with low maintenance cost. So there are two machines available in the market. There is the Iridex Cyclo G6 with the P3 probe here, and also the Supra 810 nanometer subliminal quantal laser. In the Iridex machine, basically the probe, you have to pool the patients for the usage, whereas the Contil probe, you can use it you can use it is a reusable probe. So the mechanism of action basically damages the pars plicata, causing destruction of the ciliary epithelium. There is thrombosis of the ciliary vessels. It decreases the vascular perfusion. There is ischemia and atrophy of the ciliary process. And also there's inflammation of the ciliary process, which decreases the aqueous production. So there are various indications available. So basically it's used as an end stage procedure in all refractory glaucomas with painful blind eyes. And the next, coming to the G probe. So the G probe, it allows targeted cyclophotocoagulation of the ciliary body, and the tip is about 1.2 millimeter from the corneal limbus, and there is a protrusion here that is about 0.7 millimeter beyond the contact. That this indents the conjunctiva and sclera to enhance the transmission, and the foot plate is curved spherically to match the scleral surface. So the G probe is designed to ensure that the energy is delivered more posteriorly than the fiber optic protrusion. So in certain cases like congenital glaucoma, in high myopia, and like previous surgery, there's distortion to the limbal anatomy. In such cases, you have to you should mark the ciliary body. So you can either use the microscope retroillumination, or you can use a torchlight and shine 4 millimeter away from the corneoscleral limbus, and you can see a darkened area. So this gives the position of the ciliary body, and here you can place the probe. So there are two settings where we can do the procedure. One is the standard setting. The spot size is about 16 to 24. The power is 1250 to 2500 milliwatt, and the duration is 2000 milliseconds. And then there is the slow coagulation technique, where the duration is about 3000 to 4000 milliseconds, and power is 1250 to 1500. And energy is titrated just below the level of an audible pop. And this is it is positioned 1 to 2 millimeter posterior to the limbus and is angled parallel to the visual axis, basically avoiding the 3 o'clock and 9 o'clock position. This is a G probe illuminate where there is an inbuilt transillumination which offers the transillumination for the ciliary body. So before the procedure, we have to take a detailed consent, which Roshna has already explained. So just we have to explain that there can be a post-operative pain, and also about the visual prognosis also you should tell, and also there can be retreatment and the risk and benefits of the procedure to the patient. So under peribulbar block, retrobulbar or general anesthesia, you apply lidocaine jelly and treat the superior and the inferior quadrant, basically avoiding the 3 o'clock and 9 o'clock position. So the practical considerations is the cost of the probe, that is the Iridix machine probe. It costs about 27,000, and in pigmented eyes use low power settings for a longer duration, and avoid areas of increased conjunctival pigmentation and scleral thinning. The energy should be used as minimum as possible to avoid surface burns. And when you're reusing the probe, always clean with alcohol wipes. The post-operative management is that eye should be bandaged about 6 to 8 hours. You have to prescribe oral analgesics and inflammatory medications, oral acetazolamide to basically reduce the post-operative IOP spikes. You have to continue anti-glaucoma medication and prescribe the topical steroids for 1 month. You can continue it for 2 to 3 months also. Use of topical cycloplegics to reduce the post-operative pain. The complications are basically pain. They can be initially high IOP, that is seen in 10%. They can be hypotony, thysis bulbi. They can be decreased vision in 20 to 30% of patients. There can be inflammation, hyphema, conjunctival and scleral burns, corneal decompensation, cataract, scleral thinning, staphyloma, malignant glaucoma, and sympathetic ophthalmia. So this is a case of, this is an article of scleral perforation following transscleral diode laser. It was due to the faulty laser probe. There was a debris at the probe, and also scleral thinning can contribute to this, and also localized pigmentation and scarring. So the basic is that the cost, it is a little bit towards the costlier side, but it's a well tolerated procedure with maximum IOP lowering effect, and complications like pain, decreased vision, and phthisis has been reported. Thank you.
Thank you, Dr. Nimita. Next topic is newer laser and lasers in postoperative glaucoma management by Dr. Meena Gobinath. Dr. Meena is the HOD of glaucoma department at Shankara Eye Hospital.
Thank you, Dr. Nimita and KSOS for this platform. And thank you, audience, for coming to listening to us. I hope you will have some kind of a learning from this topic. So these are some of the lasers which are in pipeline. Some are being done, but not very popular. So what are the newer lasers? I'll be covering all these topics. SLT has already been covered by Dr. Veena. So what is micropulse laser trabeculoplasty? So it's the same thing, it's a trabeculoplasty. Now what happened? Initially it started with argon laser, then went on to selective laser. So what has happened with these two lasers? There have been a lot of post-treatment complications. So the researchers attempted to reduce the amount of energy delivered by each SLT procedure. And they found that a subthreshold energy SLT could be as effective as a conventional SLT. So in 2005, these two scientists described the micropulse diode laser trabeculoplasty. Now, what is a mechanism? It's basically a continuous wave laser beam, which is cut into small, short, repetitive, low pulses energy. Now, there is always a cooling period between these brief pulses. So, there is no evidence of any cellular damage, no scarring or morphological changes. There is no thermal spreading or no IOP spikes were noted with this procedure. So this is a table which compares the MLT with SLT and ALT. So if you note here, there is no destruction of pigmented trabecular cells in MLT, and the spot size is slightly larger like SLT, 300 micrometer, and the post-operative inflammation is literally talked as none. So this is the machine which you can use for micropulse trabeculoplasty, and this is the laser trabeculoplasty lens. Usually T10 laser spots are given per clock hour in this procedure. So these are some of the studies. This is a systematic review and meta-analysis done about this. Definitely it offer a greater short-term reductions as comparable as SLT. Now, what are the limitations? So what they have found, when you see this meta-analysis, multiple researchers or multiple people have used different kind of spot size, different wavelength, different duration. So there has been not a great standardization for this procedure. So that is one of the limitation. Now, when we talk about micropulse transcleral cyclophotocoagulation, the same thing, it has got an on cycle and an off cycle, the micropulse mechanism is same, on and off cycle is there. So as Dr. Nimita was telling, when we started the diode cyclophotocoagulation, it was mainly for refractory glaucoma. So if you see micropulse diode laser photocoagulation, it can be used for early therapy of glaucomatous eyes also. So the more and more people are using in early therapy also, and best part is it can be repeated in eyes. The surgical techniques, again, there's a duty cycle which is around 31.3, and this is the latest probe which is being used. And usually it is a sweeping mechanism after giving a peribulbar block, and usually you can decide on how much quadrant you have to treat. So there are 5 modifiable factors in this, that is the total treatment time and power, and which is the area treated. Are you treating 180, 360 or some 2-3 clock hours, positioning of the probe, and the velocity of the sweeping motion. So all this can influence the clinical outcome of this disease. So the biggest downside of this procedure is that you have to pull up the patients because the probe cannot be reused. So these are some of the results which they have got in refractory glaucoma. So they consider that diode transcleral photocoagulation, both micropulse and continuous modes, which is a standard mode, are effective in lowering the intraocular pressure. The micropulse mode provided a more consistent and predictable. That means the physical chances or the ocular complications chances are very, very less when compared to the standard conventional laser photocoagulation. Now, very minimal complications, as I mentioned, there can have a little pain, rebound, increase of the intraocular pressure, and a little bit of anterior chamber inflammation. So definitely this is an option, very safe option to traditional transcleral cyclophotocoagulation. Now, the what is the downside of an SLT? Now, there is always a phobia. Don't put anything onto your eyes. So, SLT requires a gonioscope. To continue with the procedure, it can cause a blurry vision, foreign body sensation to the patient. And what happens in SLT? The laser energy, it passes through the anterior chamber to reach the trabecular meshwork. So it may affect the cornea, it can change the curvature. So there comes the use of direct selective laser trabeculoplasty or DSLLT, which was invented by Dr. Professor Michael Belkin. He is a very good Israeli scientist. Lot of inventions is so this was the first device which he invented, and now it is being taken over by Alcon, which is sold in the name of Voyager DSLT device. So in this, if you see in the Belkin, in the conventional, you have to put a the lens, whereas in Belkin Vision, it is a direct laser application without any kind of lens. So this is a study which is a randomized controlled study called Glorious study on this DSLT. So it's a multi-centric trial wherein they have compared the efficacy of DSLT against the conventional SLT in open angle glaucoma. So in this, what they use is ND-AG laser with a wavelength of 532 nanometer, and these are the parameters which they have studied in DSLT and SLT. Both DSLT and SLT was done for 360 degrees. Now, this was the way they randomized the study, wherein DSLT 98 patients were underwent DSLT and 94 patients underwent SLT. So they concluded from the study that 6 months primary endpoint did not achieve statistically non-inferiority compared with conventional. What does that mean? It is almost both of them are equally efficacious, but failure to demonstrate non-inferiority does not prove inferiority. So definitely DSLT remains an effective option in the early treatment of glaucoma. Other ones include carbon dioxide laser assisted sclerectomy surgery. It was being done, but currently the machine is not really available in Arvind Pondicherry. Dr. Venkatesh has done quite a few cases wherein you attach this arm of the machine into the microscope and you do, it is part of the deep sclerectomy, make a first flap, and for making the deeper flap, you use a carbon dioxide laser. So the carbon dioxide laser will ablate the outer layer of the Schlem's canal, and then once the Schlem's canal is opened, that's the end point, and then after that you close this flap. Now this can be either combined with phaco. They've combined with multiple procedures, like they have even combined with trabeculectomy also. So these are some of the studies which have been preliminarily done in 2012, wherein they found a complete success at 6 months and 1 year to be around 76 to 60% in these 12-month follow-up of 30 patients. Few complications, PAS, iris incarceration can happen, and these are the main causes for elevated IOP after the procedure. Femtosecond laser, which our colleagues, refractive surgeons, love it. This also has been used in glaucoma. So you all know the femtosecond, the beauty of femtosecond is it does not heat the tissue, or it does not send any kind of a cavitational shock waves. That is why it is safer in refractive surgery. So it's basically a near infrared wavelength which is used. So it is not absorbed by any transparent media. So this is a study which is first in human safety study of femtosecond laser, which is called as flight study, femtosecond laser image guided high precision trabeculotomy. So this has demonstrated that it's got a very good favorable safety profile for this. So this is a system which is used for this wireless laser system for this, and other procedure being excimer laser trabeculostomy, which again can be done as a standalone or combined with phaco. Basically, it creates holes or channels between the anterior chamber and Schlem's canal. Now, this is a probe which is used in ELT, and usually a corneal paracentesis is done, and through that the laser probe is introduced into the anterior chamber. The tip is approached under gonioscopic guidance until it touches the trabecular meshwork. So you can see there are some bubbles and bleeding which happens. That is the end point of the laser which is being done. So there have been multiple studies which have been performed on ELT procedure, which has showed a relatively good safety and effectiveness of this procedure. Now, when it comes to lasers in postoperative glaucoma, laser suture lysis post-trabeculectomy, usually using, these are the different lenses which is used. The first one is a Hoskins lens, this is a Blumenthal lens, and we can even use a rich trabeculoplasty lens also. When do we do it? Usually 2 weeks without adjuvants and 3 to 5 weeks with the usage of MMC. And this is the laser settings. Usually you can use argon laser. I use a yellow Pascal laser of 577 nanometer. You can use either 250 to 1000 microvolts with a duration of 20 to 100 milliseconds. With 1 to 3 applications, you should be able to cut. Multiple complications have been reported, but all are not very major complications. Wound dehiscence, conjunctival perforation, sudden hypotony can happen, hyphema, very, very rarely malignant glaucoma. Late complications of lenticular opacity and large filtrate blebs can happen. So this is the cut edge of the suture which is seen. So this is a patient who presented to us with a progressive myopia after a long pseudophakic history of 2013. She presented to us 2022. So shallow AC, progressive myopia, raised IOP. Raise your eyebrows. It is chronic pseudophakic malignant glaucoma. Now you can do something called IZHV. That is a surgical IZHV, iridosonulohyaloidovitrectomy. So the same thing we can perform as ND-YAG laser hyalodotomy with a NDR, PI and hyalodotomy. So usually this may be needed to be repeated as 2 to 3 sittings in a gap of 1 week to 2 weeks depending upon the response of the patient. So I'm not going into the details of malignant glaucoma. So ND-YAG laser capsulotomy and hyalodotomy should be considered. Endocyclophotocoagulation, I think partly discussed. So ECP can be approached as a pars plana or limbal approach, wherein you are directly ablating the ciliary process. So these are both pars plana as well as the limbal approach, wherein there is a direct ablation of the ciliary processes was happening. So indications, again, it was indicated for refractory glaucoma, but nowadays it has been combined with phaco, it has been combined with KDB, it has been combined with eye stent. So it can be done with good visual potential. It definitely has certain advantages. Last slide, ND-YAG laser goniopuncture. So this was used earlier in deep sclerectomy patients, that is in non-penetrating surgery, as an attempt to augment the filtration. But it can be used in even in non-functioning blebs, definitely with patent internal ostia. So it also reopens the pathway from the anterior chamber to the subconjunctival space. Thank you.
Thank you, madam, for the wonderful talk. Any doubts?
So I just wanted to add, you had mentioned the slow photocoagulation. So like the standard photocoagulation, easy way to remember is everything is 2000 millivolts, 2000 millisecond. In slow photocoagulation, generally we decrease the